Good afternoon. My name is Dr. Janice Pasieka, and I am an endocrine surgeon here at the University of Calgary. Today at the CNET's Patient Advisory Advocacy meeting, I would like to talk about survivorship issues in neuroendocrine patients. I sit on several boards. These are my disclosures, but I will also disclose that there is limited data on neuroendocrine patients talking about the various stages of survivorship and what each of you may be facing. So I draw some of my hypotheses based on the existing data from other cancer tumor groups and my own experience. The definition of survivorship is the focus on health and life of a cancer patient following initial treatment. And for those of you living with cancer in the audience, you are well aware of that it is a very complex issue that involves many domains because it is important and part of your physical health. It involves your mental health and your social health, and how these are all intertwined will dictate how you survive and move through the various survival phases of living with cancer. So my objective today is to identify some of the potential issues that are unique to neuroendocrine survivors. For those of you that are patients and for your caregivers, I hope that by the end of this, you will recognize that you are not alone, that most neuroendocrine patients have experiencing various things as they go through their journey living with this disease. For healthcare providers that may be listening, I'm hoping that this will enlighten you to recognize that you may have to alter your current practice in order to meet the needs that are unique to neuroendocrine patients. And this will also help us identify potential research projects going forward. And to the healthcare authorities and to CNETs as a patient advisory and advocacy group, wanting to show and recognize the growing needs of the patient population living with neuroendocrine tumors to try to help advocate for adapting new models of providing care. So the format is I'm going to identify the dynamic stages of a survivorship model in the role of cancer. But we also need to talk a little bit about aging, because aging is dynamic. And as we are moving through the survivorship model, we must remember that we are all getting a little bit older. I want to use some of the data from other cancer groups to identify what one should expect at each of these stages of the survivorship model, and then identify specific needs for you as a neuroendocrine patient. Now, this is Miller's model of what he calls the seasons of survivorship. And you start with the acute diagnosis that you now have cancer. Now, I've added a few extra lines because that's what I do as a surgeon. I can't accept it outright. I had to sort of modify it a bit. But really what we're talking about is there's an acute phase. And then all of us will go through some sort of transition. You'll get treated. And then there's this transitioning to then get into what we call the extended survivorship phases, whether that means it's cancer-free, whether you're being maintained in a remission, or whether you are a chronic survivor living with cancer. And all of these then will go to a permanent survivor model in which there may be long-term sequelae of the treatment. Secondary cancers are developed, and this is all part of this journey of living with cancer. On top of that, we will be moving through this. We have the aging process. And in neuroendocrine cancers, because the majority are slow-growing indolent, you will move through what we would normally experience as we age. And why is that important? Well, it is estimated that in the next 10 years, 19% of the US population will be over the age of 65. And this is something from 2015. And you can see that here now in 2020, now 21, that 2/3 of all cancer survivors are over the age of 65. And why is that important? Well, you start to develop what we call comorbidities, other illnesses as part of the aging process. Heart disease, diabetes, osteoarthritis, all of these things that all of us will experience as we age. And 80% of patients people over the age of 65 have at least one comorbidity. 50% have two. And in this cross-sectional survey of over 1,000 cancer survivor patients, the mean number of having another illness, another comorbidity, was 5. And you can see that 80% of patients that have lived 10 years since their diagnosis will have 3 or more other comorbidities. The quality of life that one experiences is directly related to the number of comorbidities that you are living with. And this is just from that study showing that at 5 years, 60% will also have hypertension, osteoarthritis, 25% will develop diabetes, heart disease, and over 20%. So as we age, we will also acquire other illnesses. So what is that unique for this for neuroendocrine patients? Well, I think that many of the primary care physicians who are very good at treating diabetes, osteoarthritis, heart disease, are more reluctant to treat and deal with these comorbidities when they have patients that are now been diagnosed with this rare tumor, neuroendocrine, and are being subjected to unique treatments that are not traditional in the world of cancer treatment. So I think we have many additive additional issues in the survivorship because of being neuroendocrine patients. So let's look at these specifically. So we'll start with the acute phase. So for cancer patients, when you are first diagnosed, it's not uncommon. Over 30% will undergo severe depression and anxiety, and PTSD is seen in over 16% of patients when they initially get that diagnosis of cancer. But what in addition happens to the neuroendocrine patients? Well, many of you are presenting with an endocrinopathy, carcinoid syndrome. And I am a firm believer that carcinoid syndrome does add a degree of cognitive dysfunction. If you've been having 8 to 10 bowel movements a day, you've already moved into a phase of social isolation because you cannot carry on your normal day-to-day activities. And this isolation puts you at greater risk of losing some of the important coping skills in dealing with that diagnosis. I think there are trust issues around it for the patients. Many of patients have been telling their primary care physicians and other physicians for years that they don't feel well, and yet the diagnosis has eluded the medical profession. Neuroendocrine tumors, at least in small bowel neuroendocrine tumors, the average delay in diagnosis is up to 5 to 6 years. And so I think there's trust issues around the medical field when you now are finally told that you have a diagnosis. And 60% of the time we're telling you that it has now been moved into the liver when we've made this diagnosis. And so there's that perception around having metastatic cancer that once it's in the liver and it's metastatic stage 4, that life is very short, measured in months. Whereas in this disease, for most patients, it's measured in years to decades. And so we have to get around that perception of stage 4 disease. And we try to help you with that, but the problem is in order to understand and know where you fit in the spectrum of this very diverse group of illness called neuroendocrine tumors, we have to define the cadence of your disease. And your disease cadence, we can't tell you at that initial acute phase of telling you the diagnosis. Well, then we've made the diagnosis, and many of you will undergo surgery. Most will be put on a somatostatin analog. There may be PRRT therapy. There may be other therapies that are done. And so you start to move into the transitional phase. And in this phase, most cancer patients have a significant degree of fatigue as they are utilizing a lot of their energy in fighting the cancer and recovering from the initial treatment. Patients at this time start to focus on getting back to normal, get my life back. But underlying all of that is this fear of recurrence or fear of progression. And we haven't been able to sort of tell you what that will look like because it's too early in the course of your disease. Many patients start to get concerned about returning to work and getting back into the normal life that they once led. In addition, for the neuroendocrine patients, well, we've got a lot of work to do as physicians on the education around this rare tumor, about the cadence, trying to define what the cadence of your particular disease would be. We have a little bit more information, but we still can't say for sure what the bigger picture will look like. At this stage, many are now transitioning into the new norm, not normal, but the new norm. Yes, you may have an improved state, less bowel movements a day, but maybe for some of you, even with our best of treatments, we still are poorly controlling your symptoms, particularly those that are presenting with carcinoid heart disease and carcinoid syndrome. Well, once we go through the transition phase, we then there is this cancer-free phase, but for most patients with neuroendocrine tumors, we do not fall into this group. You either are in the extended survivorship and the maintenance of remission. So for cancer patients, we have set an arbitrary 5-year survival goal. Most cancers, if you survive beyond 5 years, this is a very good prognostic sign that the cancer will likely be in remission. For the patient, there's a lot of fear or uncertainty getting up to that goal line. 50% of patients that get an initial diagnosis don't return to work, whether it's because they're unable to because of the treatment or they've had an epiphany and that life is more important than going to work every day. But these patients are also burdened with follow-up because we're asking you to come back to the cancer center. There's tests that have to be done to truly keep on top of and ensure that we are following closely your disease and maintaining you in this state of remission. Over time, in this extended survivor phase, most patients start to show an improvement of quality of life over time. What is there in addition to the maintained remission for a neuroendocrine patient? Well, the 5-year survival goal line is really arbitrary because it has been shown that in neuroendocrine patients, the median time to recurrence is usually over 8 years. So the follow-up period is going to be a lot longer than a 5-year period. The majority of patients that certainly I deal with at the cancer center because of my surgical involvement is patients with neuroendocrine that are in this phase living with cancer. Now, for the cancer patient, you will sort of fall into 2 groups. You either continue to receive therapy, and that may change as they change and follow the cancer that they're monitoring. Or nowadays, there's many people that would say, yes, we can see something that's in your liver. We're just going to watch it. We're not going to actively treat it. And both of those will have different effects on the patient. Many patients report fatigue, and many patients are reporting sleep difficulties. Financial concerns are important because you know you have this underlying cancer. Can you return to work? And many patients are burdened by access to follow-up and getting into the cancer center and having to travel to major centers for their follow-up. But what's in addition for the patient with neuroendocrine tumors? Well, this is a lovely survey of almost 2,000 patients living with neuroendocrine disease that Simran Singh did back in 2017. And this is the percentage of patients on the x-axis, and the green bar is the total percentage, with the blue bar showing the percentage of patients that are getting it on a daily basis. So general fatigue and malaise and weakness is seen in almost 60% of patients with neuroendocrine, and 72% of those are having it on a daily basis. Diarrhea at 50%, 41% daily basis. Abdominal pain and cramping, 40%. Blood pressure fluctuation, memory loss and confusion, and 20%, 53% on a daily basis. What is the negative impact of living with a neuroendocrine tumor and this endocrinopathy? So again, in the same surveys, over 70% found that there was a negative impact on their overall energy level, 60% on their emotional health, 50% unable to participate in leisure activities, daily life activities, a negative impact on the social life, ability to travel, and finances. So clearly the endocrinopathy is adding to the ability to have to carry on in a normal life in that survivorship phase. And then I think in addition, for the neuroendocrine patients, what are the long-term effects of the treatments that we're giving? What is the toxicity of PRRT therapy? What about the malabsorption that we create with somatostatin analogs and the secondary cancers from our liver-directed therapies and our PRRT? Are they additive? And if we're doing more different types of treatment, does that number go up? And we have to then, I always question, what about the endocrinopathy? Does it change as one ages and goes through the aging process? Finally, what about the cognition? And I was asked to talk a little bit about this. Now, cognition is the mental process or action of acquiring knowledge through understanding, thought, experience, and our senses. But cognition has numerous domains that make up our cognitive function. And here they are. So attention and concentration, language, executive function, motor function, our visual and our verbal memory are all part of what make our cognition. It's interesting that more and more research is being done in cognition of cancer patients, and it's estimated that 4.5 million cancer patients are living with some degree of cognitive impairment. And what we're now really understanding is, with an improved survival of cancer patients, that we are now shifting our focus to the therapy toxicities. What has these ongoing therapies that improve survival done to the patient? And we think we may be underappreciating the inherent cancer-related toxicities. And one of them may be the toxicity of cognition. It has been shown that 75% of cancer patients experience some degree of cognitive impairment during the course of their therapy. 35% of these, the impairment happens years after the therapy has happened. So radiation to the brain for a brain tumor, cognitive impairment 5-6 years later. But what is also very interesting to me is that 30% of patients have cognitive impairment prior to even starting treatment. So the measuring cancer-related cognitive impairment is something that all researchers in cancer care are now looking at and including in any studies that we do. But this becomes a real challenge because cognition, as we said, is multifaceted and is altered by anxiety and stress, fatigue, sleep disruption, the age, education, depression, coping factors, and comorbidities. And as we talked about, these are all happening to you as a cancer survivor. And how do we separate those out? The cognitive impairment in carcinoid syndrome, I don't know. Is it related to the anxiety and the depression? Is it related to serotonin or some peptide that is being produced by these hormones? Is it related to a tryptophan deficiency, which is the building block to making serotonin? Is it about neuroendocrine inflammatory response because these are neuroendocrine tumors producing different peptides? Or is it even related to our somatostatin analogs? A lot of questions that need to be answered, and one in which we're hoping to be able to at least try to answer through research grants that we have been awarded through CNETs and other agencies. So, in summary, the survivorship issues of patients with neuroendocrine tumors is very different than a cancer patient solely, because you're also living with an endocrinopathy, and the majority are living with cancer, not in a remission. This is a very diverse group of patients that all have a different cadence in the disease, and therefore each of you will go through the survivorship model that I outlined at a very different speed. There's little data to enlighten us on the long-term effects of the therapies that we are giving today, and we always have to keep in effect and keep remembering the effects of aging as we go through. So I hope I've been able to meet my objectives and identified some of the potential issues, and that you as patients and caregivers recognize you're not alone, and that CNETS recognizes as a patient advocacy group that we need to adapt new models for providing care through, at the health authority level and at the level of the healthcare provider. So thank you very much, and I appreciate your attention today.